All right, folks, we're going to move on, change gears a bit, and head into our hospital updates. We'll be having 3 presentations, and the first will be from Dr. Kathi Wells about the CHoSEN Quick Perinatal Navigator Program. Dr. Wells is the Executive Director of the Kempe Center for the Prevention and Treatment of Child Abuse and Neglect, and Associate Professor of the University of Colorado School of Medicine in the Department of Pediatrics. Thank you, Dr. Wells, for your time.
Yeah, it's great to see you all, or see some of you. I agree with your comments earlier on. I wish that we could all be together, but glad that we still have this sort of platform to connect. I'm going to share my screen, I hope. And please tell me if you don't see the slideshow format here in 1 second. And while I do this, I just want to extend my gratitude for organizing this great session. I had to jump off for another meeting for a little while, but what I've heard has been wonderful, and the inspiration of a couple of your keynoters, including Rob, just is really wonderful, and just grounds us in possibility and potential and opportunity that we have collectively and individually to make a difference for the kids and families and systems that we work with. So I'm duly inspired, and hope that our little project continues on the path towards helping others as well. So as a bit of an, first of all, I want to give some acknowledgement. Jenny Cook-Zappel is our sort of Kemp's lead in this project. Couldn't be here today, so she handed the reins to me, but I really have to extend gratitude to her, to Lauren, to Lori, to all the people that have been helping, and honestly to you, Susan, as well, for sort of letting us partner with you on this project. Lots of folks have been involved in this, some of which I know are in the meeting and on the call. So just as a little bit of a kind of an update where we are. So I just want to kind of remind folks, or folks that may not know where this came from. This is really sort of an effort to sort of think about how do we bridge the space, or how do we help mom baby dyads or families bridge the space between when a baby or when a pregnant or parenting mom or individual is identified as having substance use disorder, and how do we make sure that as that mom baby dyad or family system transitions out of the newborn nursery, where we know that really great interventions like the CHoSEN Quick intervention and Eat, Sleep, Console, those, all the powerful work that you've all done to show the impact of that kind of intervention. How do we know that that transition home at that very critical time, right? Is we heard data earlier about the increased risk of substance use. How do we know what happens to those folks, and how do we create systems that better bridges that gap, as well as how do we continue to push upstream, right? So how do we do a better job of either preventing that from occurring entirely, or when we identify someone who's pregnant, who has a substance use disorder, how do we engage with them then? And so we elected to kind of pilot this little project within the Denver health system, mainly because of some work that had already been done there in terms of developing the prenatal part of the system, and some partnerships that were already in place between Human Services and Denver Health in terms of the Nurse Family Wellness Program that was already existing, where nurses were working with risk families to support them. And so the plan was, originally to have the navigator sit within the Denver Health Family Wellness Program, that is Denver Health providers that are supported by Human Services, which would also allow us to better work with Human Services. But again, as much as possible proactively or prior to a family's formal involvement. And so working with those kind of current programs, and then really to identify the current referral pathways and then build into those. And so the original plan was to really think about 4 main pathways, and that was getting families referred through the current integrated care program for women and babies, and really being able to connect them with a nurse or social work educator around infant specific work, and what are the expectations of the baby, and how families can be supported in that structure. And those referrals would, that program currently is serving Denver Health's Women's Clinic, as well as East Side and West Side. And then next would be those families that were currently already being referred in to the Denver Department of Human Services child welfare through a report. So that might be someone who's actually screened in for assessment and potentially even an open case for resources, or it might be someone who maybe is pregnant, doesn't have any other children. So Human Services would not be able to be involved until that baby delivers, but could we serve that family, hopefully to avoid formal child welfare involvement. And then another place that Denver Human Services touches families is they have families that may connect through just a complex care team that currently exists. So not through child welfare referral. They might be working with families and other needs that the family might have. And then could there be referrals of women that present for care in the emergency department or other Denver Health clinics for a variety of reasons, but then are identified as being someone who's pregnant with substance use disorder who might benefit from these resources. And then we also thought about how could the current nurse social work educator working with the pregnant person and how could the pregnant person enter the program and work with the worker. So kind of those two different routes. So that was sort of where we started, just to kind of update folks where we're at. So Denver Health has applied for Medicaid or HCPOF's maternal opioid misuse grant to really sort of apply that Perinatal Navigator Program model and actually provide some financial support for both a professional navigator like a social worker, nurse, and or also building in support for family recovery support folks, right? So peer support that really could bring an additional lens of value, just as we've heard quite a bit today, right? The value of someone who has walked in similar shoes or had similar experiences. So if that is funded, we're really excited about that, including actual funding support for some structure around that peer support and reflective supervision, right? Because I think it's really important that we sort of manage that in a way that doesn't potentially place risk for that peer support person without providing some supervision for them as well. So we're still piloting the programs at the Denver Health System and working to sort of identify those referral pathways so that we don't have to wait to hear about the mom funding. If the mom funding comes through, it really just kind of provide additional supports. And the plan really is to figure out who are those families that can be served through the nurse navigators, both through the current Family Wellness Center. And one of the things that came up is we really want to be very careful that families that aren't currently involved in the child welfare system don't view this as child welfare system involvement. And so we've been working closely with Denver Human Services around that, and they've actually been really supportive in thinking about, are there other funding streams that could help support that team that wouldn't necessarily come to child welfare? And is there a way to communicate with families so that they don't feel like this is a backdoor to child welfare, which is not the intention of the program whatsoever. So currently working with those that get referred and then looking to be able to potentially build that out with additional funding. A couple other areas that we are working with is UC Health has a pilot project through the emergency department. So we're really excited about sort of being able to identify a pregnant person who comes through the emergency department for care for any reason. That might be a time of real opportunity and potential to be able to engage with someone by utilizing a social worker or a patient navigator, and then giving them resources and really more than just sort of handing a paper, but really giving them access to a QR code, a referral site, so that we really can try to create a warm handoff or a warm connection to resources that may be available, and also understanding the potential language barriers and building resources in that would be both Spanish and English. And then ultimately thinking about what do we learn from this process that could potentially be replicated elsewhere. So really starting to think about how do we develop a model and a way to assess readiness in other systems. We know there's some other, and I know you're going to hear about a couple of them today, some other really, I think, exciting programs. So how do we learn and work together about what things work, what things don't work, and what might be the recipe, right? So what might be the the certain circumstances that might need to be in place in order to create better impact when these kinds of programs are initiated, and what resources communities might need to implement a model like this. So, the hope here, and I think honestly, the CHoSEN Quick program has really demonstrated this, that we can think big, we can think about what we're learning here and how this can be a model beyond even just Colorado or the region. And we certainly are reaching out to and working with other folks around the country that are doing some similar kinds of things and really trying to figure out how do we be able to show impact as well, right? So it's one thing to have a program that we feel really good about, but how can we really show impact so that supports sustainability when funding streams don't look as maybe right now we've got an influx of potential resources. How do we study this in a way that we can demonstrate impact longer term? So really our plan is to use these lessons learned from this little pilot, partnering with other folks that are doing similar things, and then thinking about what that framework might look like so that we can, and what does it look like to work with the community to determine whether what they need in terms of their own readiness, preparedness for this kind of a QI project. Just a couple comments about, these are probably not unique to us. In fact, I know they're not unique to us, but the challenges we continue to think about is data, right? Like, so where does that data live? Especially when we have, even from the very client standpoint or family or mom, baby, parent, baby dyad, is that may be within the healthcare system. There may be information within treatment systems. And then of course we may have other systems like funding systems and health and child welfare systems that may have some data. And I think to best understand the impact of these interventions, the more we can link data across those systems, the better off we are. But the real question is, where does that data sort of formally live? Obviously, we have regulatory issues in our little program. We have this pilot within UC Health. We are formalizing our larger pilot within Member Health, but those are two different health systems. So how do we make sure that, again, we can link data or at least share data for service and or for studying impact, but not violate things like confidentiality. And particularly when we're talking about a really protected group, as it should be, like we are here, which is pregnant women and babies. We want to make sure that we're addressing all those things. And then just staffing, right? So as we're talking about a navigator role, really trying to think about, are there something like the student intern? It's so difficult right now. I don't have to tell all of you this, but this is, COVID has made it even more difficult to really engage, honestly, some very bright students that may really be interested in doing this work, but there are some limitations. So I think that was another big challenge, was to really have someone jump into that role full time and have that capacity. So I just put these contexts here. As I said, I'm really just singing the praises of Jenny and the rest of the team that's doing this work and doing what I can to support and think more largely. I actually presented for the American Academy of Pediatrics in the Child Abuse Council group with some of my colleagues around the country last weekend. And I think it's exciting. I think what is happening here in Colorado, I think really can be a model for others. And so with that, I don't know if there are questions or clarifications.
Thank you so much, Kathi. I think what we're going to do is go through all presentations and then we'll have an open Q&A session.
Perfect. Thank you.
Thank you. Next, we'll have a presentation from Amy Dempsey, who comes to us from the Lutheran Medical Center, and she'll talk about a systems level approach in navigating substance use disorder, truly as a systems initiative.
Okay, let me try that. I know.
We've got a bit of an echo.
Try that.
Perfect.
Any better?
Excellent.
Okay, great. So my name is Amy, and I'm the clinical specialist at Lutheran. And we've been a part of the CHoSEN collaborative for quite some time. And I just was asked to share a little bit about what we were doing in terms of our perinatal services. So I've been completely humbled by this conference. Actually, each time I attend, I learn so much. And today was just really taken aback by the vulnerability that was shared. I have noticed a few things working on this project at my hospital. The first is that alcohol is normalized and celebrated amongst my colleagues, and opioid addiction, not so much. And I have found that very interesting. I've also noticed that it's really easy for me to get my pediatricians on board to care for substance exposed newborns, but it's been a bit of a challenge to get my obstetricians committed to caring for the maternal patient population. And ironically, this comes amidst noticing that my staff are really impacted by this in their own families, and in the with their children and their spouses and with themselves. And so I've just been noticing these trends and feeling compelled to figure out how we can help our moms who are really struggling with addiction. This isn't going to go away either. So we're noticing a rise. I noticed this weekend that 3 out of the 5 babies in our NICU are substance exposed newborns. And that's just, it's not going to go away. So we need to figure out how we can address these issues. So I'm a part of a system, and I noticed also that each individual hospital was working on doing some things that were really amazing. So Lutheran has a resource, a nurse recovery advocate program. My sister hospital in Billings was working on expert training and funded by a grant. And my sister hospital over in Grand Junction, St. Mary's, was working on screening patients. So I was like, okay, we've got to stop working in silos. How can we do this together? So my system enrolled in the perinatal, or in the Colorado AIM Substance Use Disorder Collaborative, all 8 hospitals. So we can start advancing through these slides. SCL Health is a nonprofit healthcare organization, and they are committed to improving the health of the underserved. So I love that. We also have a mental health service, West Pines, which is a benefit because we can partner with them. So there's 8 hospitals, 3 in Montana and 5 in Colorado. Go on. And we gathered together to create this amazing team. I grabbed a few pictures of some of our key members. 2 of the pictures are of subject matter experts. We do have an addiction medicine specialist, Dr. Jackman. And I put a picture in here of Michelle, who's our nurse recovery advocate here in the Denver metro area. And there she is in front of the Capitol, working with Illuminate to advocate for some legislation. And then Colleen is a member of the CHoSEN program, so one of our NICU representatives. You can go on. 8 hospitals is a little bit like herding cats. We have 1 member at least from each of our hospitals. And I just wanted to point out that as we go to the next slide, this is a huge, this is our SCL AIM statement. Huge undertaking to have all 8 hospitals represented. And we came together to create a mission vision statement and a team purpose and created a charter. And if you go on, I think I put an overview of the 8 hospitals. So these 4 are the urban Denver metro hospitals. St. Joseph is one of the highest delivering volume hospitals in our area. Lutheran and Good Samaritan and Platte Valley represent more suburbia. And then if you go on, there's the other 8, or the other 4 of the 8. St. Mary's is representing Grand Junction. And then St. Vincent's is in Billings, so represents a little bit more, it's mimics Lutheran and St. Mary's. St. James and Holy Rosary, they're really serving very small patient populations, and actually Holy Rosary is critical access. And this just summarized our patient volume. So together, working together, we really have about 4,000, a little over 4,000 annual deliveries. So our first thing that we decided to do was tackle looking at our current screening rates. And we are using a blend of screening tools. What we decided, though, ultimately was that we needed a standardized tool, and we needed to build it into Epic. And so while we're reporting what our current scores are, they're really not reflective of a meaningful tool. We want to move to audit C+2. And so we unanimously decided, yes, we would use this tool, and yes, we would build it into Epic. And so with that comes a few barriers, because build teams don't always work at the same rate as nurses. So while we want to implement this yesterday, building something into Epic takes some time, energy, and at any rate, I'll show you the next screen. This is what we're currently using, which is sort of built into our H&P section that nurses and providers both have access to. And this flows into our pediatric and OB notes. So we recognize that whatever we build, we want us to all have access to, and we want it to flow into notes. So the next screen, I believe, shows the audit C+2 tool that we've agreed that we're going to use. I think it will nicely capture screening data, and it will be universal. And the next screen shows the social determinants of health Epic build that we're headed into. So we thought we were going to go live this month, but that's been delayed. I think a realistic timeline is first quarter of 2022, which will be here before we know it. And the social determinants of health really captures all things case management related. And a piece of this on the next screen shows what the audit C+2 will look like. So if a patient screens positive, it will turn red. And then if you drill down and hover over that tab, it will then give you what triggered the positive screen. And so right now, it looks great. Some of my things or concerns are, how are we going to trigger every nurse to do this screening? So we need to come up with that plan, but then we also need to make sure this information flows to provider notes. And if we go on, some of the other things that we have worked on is, well, let me close the loop with our screening. We also have worked on a site-based policy that looks at screening intervals, starting in the clinic, going all the way through labor and delivery, and then again postpartum. So we've come to agreement on those intervals, and the policy is in the process of approval, and we'll have a site-wide policy that not only looks at maternal mental health and EPDS screening, but also on audit C+2. So I'm thrilled. That's been, for those of you who work in systems, this has been a huge accomplishment to come up with an agreed upon policy. And then we've also looked at, well, once we identify patients, how are we going to get them into treatment for those patients who are open to treatment? And so we've compiled an entire list that incorporates every single region. You can see on the bottom, Denver Metro, Western Slope, and Montana, and then also telehealth. And then we have linked this onto our portal for the system, so that everyone can access it no matter what region you're in. So next slide. And then right now we're in the process of identifying who at each site is going to get expert training. And then we have access to online expert training, which was really key because we're working with critical access rural areas in Montana. We wanted to make sure that they had access to the same training. So while in Denver Metro, we can have access to all-day trainings at no cost and do support that model, we also wanted to identify ways that rural America could benefit from the same training. Next slide. So I think in summary, gosh, we are so excited to have the CHoSEN collaborative support. We're excited to have CPCQC giving us the substance use disorder collaborative support. I'm thrilled we've got subject matter experts. I'm not a subject matter expert, but I am somebody with experience leading teams. And so together we can partner, and this is what we've come up with as a system. I'm a little bit overwhelmed sitting through this collaborative today because I realize we're not done with our work and we still have a lot to do, but we're just going to do it one step at a time. And these are the 3 things that we've accomplished. Standardizing workflow through Epic and our policy, and making resources available to providers who need to link patients to resources, and coming up with a standardized tool. So we're getting there. Now to tackle Narcan in the OB unit. That'll be next. And getting my providers to order buprenorphine. That's next on our list too.
Thank you so much, Amy. And I would say you absolutely are a subject matter expert around how do you grant access to these evidence-based, service models. So thank you for your expertise. Next, we will have presentations from CHoSEN Minnick and Lacrecia Smith, who are both care coordinators at St. Louis Valley, and they'll be sharing their work focused on integrated care for women and infants.
Hi, can you guys hear me okay?
Yes.
Awesome. I'm Lacrecia Smith. CHoSEN Minnick, she was also going to co-present with me, but she is out this week. CHoSEN Minnick is the care coordinator for our OB/GYN department. She is more boots on the ground for our ICWB grant, which is our integrated care for women and babies. That focuses on substance use disorder with our female population, our pregnant moms, so anyone that comes in through the OB clinic. And I am the care coordination manager for SCL Health. We also have another grant that we work under, it's the HRSA grant, that it's really similar to the ICWB grant as well, in that it focuses on substance use disorder and our female population. And we were just recently able to hire another care coordinator to help with those efforts, to help more in our emergency department and in our specialty clinics, so that way we can better outreach more of that population, especially that comes in through the emergency department in hospitals. So we're really excited about that. One of the things that I didn't include, well, Sherry's put it in the presentation, but we didn't get a chance to include in there is how we identify our patients that's coming in and how we get them into the program. Whenever in our EHR system, our nursing staff, whenever they do their registration and check-in process with our patients, if any of them identify any substance use disorder, they are immediately referred to speak with our care coordinator and get them into our program, so that way we can help with MAT, looking at different treatment options, resources. And then of course, any of our patients, regardless if they come in OB through any avenue, if they identify any substance use disorder or wanting more information on our MAT program, we look to see if they fit more on primary care side, if it's more of OB, getting them in there. So we're working on different avenues to get patients in to make them more aware of the program that we have, and hoping to get some more patients involved in there. In our OBGYN department, we have 6 total providers. 3 of them currently provide MAT treatment for our patients that are seeking substance use treatment. We're hoping to get a couple more providers on board, but currently only 3 of the 6 providers provide treatment. We've had a total of 33 patients start in our program through the ICWB and HRSA grant. We have 10 patients that started from the beginning when we started the program in March. And we've had a couple barriers, but we do have 4 compliant patients that are currently pregnant. They are coming to their follow-up appointments. They're following all the instructions that are given to them. So those 4 patients are our greatest success stories. Follow-ups has been the main barrier, but we continue to do outreach to any of the patients that's in the program. If they miss any appointments, if they need to reschedule, identifying if there's any barriers to getting them in. We do have some that, you know, they dodge our calls, but we're pretty diligent about keeping those follow-up calls, and eventually they answer and they might want to come back in. But we continue those outreach efforts to them. Next. When we get our patients into the program, all of our patients, we create care plans with them. They're pretty robust. We're identifying any barriers that they might have, and we make our care plans. We try to make them more patient-centered, so that way the patients, they're identifying barriers that they have, they're identifying goals that they have, because we all know that if the patients aren't involved in their care, they're more likely not to follow it. So when we're making these care plans with them, you know, we're identifying, like, what is your reason, you know, for quitting? Like, what do you have to look forward to? Like, how is this going to affect you in the long run? We get behavioral health involved in their care. That's part of the process, and try and get them to engage, you know, at least once a month in behavioral health, but definitely more is necessary if we can get them in. And we do those warm handoffs to behavioral health in the clinic. With that, we're identifying those social determinants of health. So if they're needing, like, housing, which has been a big thing with our patients, is, you know, we get them into the program and they don't have a safe place that they can go and withdraw before we start them on medications, or they have housing, but they have all of these triggers there. So just finding adequate housing and safe housing for them. We assist patients with transportation. One of the things we're looking for is, you know, you're here for the appointment. If they leave, are we able to get them back? So we can help set that up for them, where it's no cost to the patient, especially if they have Medicaid. We have that non-emergency medical transportation program. If it's a medication concern, we have programs that we use that we can help with that. We have a foundation program that we use, and the Pay It Forward program. So if we do have those patients that, you know, they aren't able to afford their medications, we can help get those for them. One of the things that we have trialed and has proven to be a good success in getting patients to come back for follow-up appointments is we have this fishbowl idea that, you know, we have the patients come in, and they come in for their follow-up appointments, you know, they're able to pull from this bowl and, like, you know, get a gift card for, you know, $5, you know, to our city market or Walmart, you know, $10 gas card. So those incentives for keeping the patients on track the patients really seem to enjoy that. They have something to look forward to when they come to those appointments. And that's something that we've also incorporated in our primary care department for our MAT patients as well. We've had 7 successful patients altogether that's either moved away, have remained in treatment, working on their sobriety. Sharice, unfortunately, who's not here, would have more specifics of those stories since she works more with the patients, but always wins in our books and hoping to increase that number. Barriers and challenges, housing, I think is just everywhere. We just don't have adequate housing, available housing, and just getting patients into the program. They're not ready, but we still keep them on our list and outreach them. And what I try to explain is, you know, they're not ready right now, but somewhere down the line they will be, and they'll know how to access us. Follow-up appointments, you know, they're ready, or they say they're ready and we just can't get them in for follow-ups. Another program that we work with our programs, we have a MAT program specifically for our area that includes not just us, but a couple of our medical facilities, that some of the patients that come in, we don't have a way to contact them. They don't have a working phone. So if they're enrolled in our program, we're able to offer them like one of the prepaid cell phones. We're able to put minutes on those phones for them if they run out, with the understanding like this is your lifeline to connect with us. Like, we're giving you this, we need to be able to reach you, and they know that like this is their only way to contact even family members. And so in order to keep that phone on, that they need to come to their follow-up appointments. So that's been successful as well. And I think getting our providers on board, both within our OB and our primary care department. Of course, we have more providers in primary care that's on board with our MAT patients, but I think the providers are seeing more of like the benefit, and I say that more with the providers that aren't waivered to do our MAT treatment. Like, they're seeing the benefits of our patients that are successfully like going through the program and the need. And I think it's more of a hesitation of the program and the time it takes, because we do offer both in-clinic inductions, and if we have patients that fit into where like a home induction would be a better fit, so we try and give them different routes. I think just getting the providers comfortable with the process and prescribing medications, I think we can get more providers on board. But overall, I think those are the barriers and challenges that are more prevalent with the patients. So we're always figuring out ways on how we can make our program more successful. With our HRSA grant, what we're working on now is working more with the jails, like the population that we have in the jails, and making sure that the females in there are getting access to medical care and treatment when they come in. So we have a care coordinator that's working there to get those patients in. We are in the process of implementing a Circle of Parents program. So that way they have that peer support, you know, from others that are going through the same things as them, as well as the Circle of Parents, because of course, or Circle of Children, because of course, you know, parents can't go to these meetings if they have kids. So the Circle of Children's group will be more of a, you know, the children have a place to go while the parents are going through this group. So that is in the works. So we'll hopefully have an update on how that goes.
Fantastic. Thank you so much. That is such exciting work. Before we go on to next steps, I do want to leave some time for questions. You know, we've had 3 really creative approaches to better supporting birthing individuals during pregnancy that are impacted by substance use. And I know that many who are on this call are interested in starting such programs in their local areas. So please chat in or unmute yourself to ask a question. While folks are thinking, I'll start off. You know, I think the San Luis Valley kind of work kind of touched upon it, but what is the time from referral to actual kind of meeting with a navigator and receipt of services, or perhaps even an evaluation of what those needs are? I recognize that it can't happen instantly, but do we have a sense of how quickly or not that initial kind of intake or evaluation happens?
This is Lacrecia. For us, once the patient comes into their appointment, they're meeting with our care coordinators within the OBGYN department. So they're going into the appointment with them. And then from there, once we identify a barrier, we're working on that. So it's at time of service for us.
It's almost in real time. That's amazing. And do any of your programs, are you structured to address the partner of the birthing individual with the substance use? How does that play into supporting a woman through her recovery? This is really a question for all the panelists.
I guess I can speak that first real quick. You know, I think we really want to think about this in the larger context of the family system and anyone who is involved. So I think that's the hope at sort of a broader approach in terms of having peer navigator support, having social work / nursing navigator to be thinking about how we can link to the right resources and programs that would support the broader needs, rather than just sort of focusing on just one aspect of either the pregnant person's substance use disorder and or that mom-baby dyad.
Other questions, folks? All right then. Well, thank you so much for our panelists, and we look forward to hearing updates from your work, probably for the spring forum. You know, so expect to hear from me again to present in April of 2022. Hopefully, it'll be in person. But thank you so much.